What are the rules of the roads? Why do we do it the way that we do it? And quite frankly, at the time, I kept thinking, I'm missing something here. I don't understand this. Like, why is what they're passing what they're passing? Maybe sounds a little naive and simplistic. And I kept thinking that perhaps I just didn't understand the playing field.
A safe haven for innovators to go off the rails. Welcome back to the Off the Rails podcast, a show about the runaway train that is our healthcare system and the innovators working to derail it. This is your host, Sydney Haytoff, and today we're joined by Josh Archambeau. Josh, thanks for joining us.
Thanks so much for having me on.
Of course. So, Josh, we usually like to start with a couple of boilerplate questions that I ask everyone. We'll go ahead and do that. I'm excited, though, to jump into this conversation, just given the hype around the legislation that you were instrumental, if not solely responsible for pushing out there to help patients apply cash payments that they make to doctors towards in-network deductibles. I just wanted to start off by saying thank you and kudos, and look forward to diving in. But first, questions. What's your occupation? Where do you work? What's your favorite food? And do you have any pets?
Oh, hard-hitting questions. All right. Let's dig right into it. I actually wear a few different hats these days, but primarily in the public policy world. Cicero Institute, which is a multi-state think tank, headquartered in Austin, Texas, but working in, I think, 20 states as of today, of the recording of this. And Cicero works on a number of different policy issues, healthcare being one of them, really trying to focus on incentives and trying to make sure that the delivery of mostly public programs or other programs that the government touches some way in through regulation or law is aligned properly to get the outcomes that we so desire as society. And there are plenty of legacy systems and status quo public policy issues that I think most Americans, right, left, center, would agree are not delivering on those outcomes. So that is how I spend a good amount of my time working with Cicero in the team there. I'm one of 4 or 5 there working in this space. And then I also help run a nonprofit called Reformers Academy. And we run an academy called Health Reformers Academy, which is trying to train more young and mid-career folks to go into public policy and healthcare, because for the last few decades, we feel like that the talent level hasn't been up to the task to make sure that we're having an intelligent, informed conversation for the betterment of all Americans. In terms of my favorite food, good question. Probably depends on the day. I would generally say maybe Italian food as a category. If I had to be more specific, pizza in general, although as somebody who is getting a little bit older every year, I have learned recently that I'm not supposed to eat yeast. So that rules out a whole subcategory of favorite food. So sourdough pizza for me these days is the go-to. I'm allowed to eat that. And then as far as pets in my household, there are 0 pets today. My children in the home object strongly to this and lobby probably twice a week for a cat or a dog, but I have not fallen prey to that quite yet. We want to be out on the road moving and grooving, and that's a lot harder when you get pets in the house. So,
Amen to that. The moving and grooving with pets. I have a big wolf-looking dog, and she's flown with me a number of times, but it is definitely not as easy. And I'm sure with kids, that would be even worse. I don't have any kids, thankfully, yet. But no, let's dive in. What brought you to, or what got you to this point with Cicero and with your career with regards to policy and specifically around healthcare? Was it always going to be healthcare? Is there any particular event that occurred in your life or family, et cetera, that led you to healthcare?
Probably the moment I worked for Governor Mitt Romney when he was governor in Massachusetts, and he signed Romneycare at the time when I was there. And that was a little bit of a trial by fire of what is this situation on healthcare. Now, my dad was, in hindsight, a pharmacist. And so growing up would hear dribs and drabs about that, visiting him at the hospital and hearing about, became a consultant and traveled around the country. And so I got to hear about different health systems and some of the frustrations that he was running into. So perhaps that was influencing my thinking even then. But it really was during Romneycare and trying to understand the complexities of what does government control? What are the rules of the roads? Why do we do it the way that we do it? And quite frankly, at the time, I kept thinking, I'm missing something here. I don't understand this. Like, why is what they're passing what they're passing? Maybe sounds a little naive and simplistic. And I kept thinking that perhaps I just didn't understand the playing field. Now, there's probably some truth to that as a relatively young person getting into public policy. You have to understand the rules of the road and how the negotiations happen. And that's what I realized over time was that more often than not, public policy is being made through negotiation. At the time, I thought it was whoever has the best data, the most convincing argument, what's going to be best for the most people is what's going to win the day. And clearly that isn't always the case. That's why we ended up in part with the system I think that we have. But going through that process when I was working for Governor Romney, came to realize that it's almost its own language. And once you learn the basic terminology, there are many people who are very curious to talk to you. Explain this to me, whether it's people in your everyday life or whether it's people who have a self-interest, financial interest, if you will, in the outcomes of those public policy debates. And so I'd say at that point, that's when my interest was piqued. Early in my career, I realized I was more of a policy nerd than I was a political nerd. And so when I was given the option to join the campaign world, I decided, no, I'd like to stay in the policy world. And I didn't work on healthcare full time after that. It was probably 5 or 6 years later that I actually made the conscious decision after graduate school to say, I think can be a rewarding career. There are people who are getting screwed under the status quo. This isn't right. I need to try to do something about it. One way to do that is through public policy. That's where so many of the decisions are being made on healthcare and have continued to be made. My thesis was right. Government, federal, and states have only gotten probably more involved since I started down this pathway. And so that's what has put me down this road, has kept me in this world. This can be a very complex career where I can look at policies from many different angles and have some success. Over my career, I've had about 105 policy changes that I feel like I've played some role in. Certainly I'm not the sole person, but trying to bring good ideas to the table and then working with policymakers to get them across the finish line.
Hell yeah. Okay. Thanks. First off, I feel like that's a frequent refrain that I hear is that people are upset about others getting screwed and realizing that something's not right with the system. That's definitely why I'm here. Kudos to you for that. Quick question about Romneycare. Is it true, and I've dug into this a little bit, but definitely not enough, that laid the blueprint for Obamacare and essentially the ACA?
Oh, complex question. There are some similarities without a doubt. But I actually spent a summer doing a fellowship in DC the summer after the ACA or Obamacare passed. And so once again, fate would have it, a deep dive on what was passed there. I think Nancy Pelosi joked she had to pass it to see what was in it. And I was there the summer after. And so me and thousands of others were figuring out what was in it. And I came to realize I was probably one of about 3 to 5 people in the entire country who knew the similarities and the differences. So starting generally in the similarities, they wanted to use subsidies to expand coverage on the private marketplace. So there are similarities. The exchanges, the marketplace, in Massachusetts, they called it the connector. There are similarities. The mechanism for distributing the health insurance coverage and the subsidies, similarities there. But there are some pretty radical differences that I don't think people fully appreciated at the time. In fact, Massachusetts folks didn't fully appreciate when the federal law passed, and when they implemented ran into huge problems. And actually wrote a report with some whistleblowers came to us and wrote a report that actually opened an FBI investigation about Massachusetts lying to the federal government about its progress using federal funds to set up their exchange. But there's some really big differences I'll just highlight. One is in Massachusetts, they had already expanded Medicaid previously, and they were using state funds to cover the vast majority of people. So the starting place for a place like New Mexico versus Massachusetts was very different. There was a culture of insurance. The offer rates for insurance from small employers, even, or mid-sized employers, was very high compared to everybody else in the country. And so when Romneycare passed, they put in provisions called anti-crowd-out provisions, which said that if you're offered insurance, you may not access public coverage. You have to either turn down your employer-based coverage or go without insurance. Obamacare didn't do that. They changed the dynamic, removed that guard, didn't copycat that. And so as a result, you saw a lot more people on not only on the exchange plan, subsidized plans, but you also saw a lot more people on Medicaid. And so I think there was just a fundamental, I don't know the quite phrase, some disingenuousness of folks going to DC and selling it and saying this is exactly what you need to do, even though our country is far too diverse and most of it does not look like Massachusetts with very high paying white collar jobs for the most part that would not be impacted by this law. And then the other political reality at the time is that Massachusetts elected a Republican to the Senate, Scott Brown. And at the time, the bill that was going through the Senate that became Obamacare or the ACA was never the final bill that they wanted to pass. They were going to put it into conference committee in DC, fix it up, and then pass the final version. And when Scott Brown got elected, he simply said, I'm not voting for this. And so what ended up becoming the law of the land was a snapshot of a draft bill, quite frankly, at the federal level. And so there were a lot of unintended consequences around those bills. Now, I was not part of the negotiations at the federal level. I don't know exactly what the intention to change was, but I've talked to people who were, and there were dozens of provisions that they either intended to take out or change in some fundamental way before it became federal law. But because of the political reality at the time, they ended up passing it. Again, structure at the very highest level, some similarities. Yes, probably the inspiration for them to move forward, but the reality of how it was implemented, the scope and its impact on different populations, fundamentally different. And there were provisions there that simply did not exist in the Massachusetts law. Some of them have been repealed at the federal level, but they just weren't there in the Massachusetts law. And so I hesitate to say that they're the exact same. There are some really important differences.
Awesome. Yeah, it sounds like it. And thank you for that thorough explanation description. If you had to pick one characteristic of Obamacare that you would change, and one that it could either be one that was strike down or strike or not. But yeah, what's the one thing, and conversely, what's the one thing that you appreciate about Obamacare? And not that I'm a fan of Obamacare.
Yeah.
It's one of those, it's an interesting line, I think, that can be drawn with regards to policy and viewpoints in healthcare. And it is so dynamic, and it's interesting to hear that it potentially wasn't, the final draft wasn't as intended. And yeah, just curious.
Yeah, hard to pick one or two here, but I think one of the areas that is most concerning to me about the law, this might be somewhat surprising, but it's the Medicaid expansion, the way they set up the financing structure. If people remember and go back and look at speeches that President Obama made during his campaign, he said, I don't want to put anybody else on Medicaid because access to issue and the outcomes are so poor. But the vast majority of people who gained coverage through Obamacare or the ACA is on Medicaid. And so those fundamental issues have not gone away. And in fact, they've probably gotten worse as you've dumped many able-bodied adults without dependence onto the program, fighting for resources that have a higher reimbursement rate when a state spends $1 than a traditional Medicaid disabled child or something like that. It leads to huge unintended consequences that I don't think people fully appreciate. Deeply concerning to me. I think the subsidy structure is also concerning to me and has led to a lot of inflation in the insurance market. And I mean, if you spend any time traveling the country talking to small business about how their insurance has changed since the law, they're simply being crushed. And as a result, a lot of them are dropping coverage. And that's where I think you're seeing more and more people in the individual market on getting subsidies or going onto Medicaid, because small business certainly in most parts of the countries were not helped by the law. In terms of something that I wish stayed, I don't know if the exact structure was right, but the Cadillac tax capping the employer exemption for the generosity of employer-based insurance is a long-standing debate that has agreement on both the right and the left, at least in the economics world, that the way we've structured our health system with tying insurance to your employer and really having it being an open-ended benefit is inflationary and really not leading to the kinds of outcomes that we want, or kinds of employee engagement or even employer engagement and thinking through how to tackle some of these cost issues that we have. I would have liked to see that stay in some form. Again, there's debate on exactly if it should have been tweaked in some way, but that general principle of making sure that we're not just letting rich people get huge benefits by having very generous health plans that's leading to some of this dysfunction would have been something I would have loved to tackle. All right, last one, I think, and keep me honest. I haven't answered all your questions. Things that I liked, I think the general goal of the law to make sure that people can access care is a good one. I question whether giving everybody an insurance card is the best way to do that. And if you go back and look at the research on this, somebody just has to go back and look at the 1970s, early 80s RAND study, where they ran a randomized controlled experiment. RAND actually started an insurance company at the time to do this. And they gave people different kinds of insurance, different plan designs. Some had to pay nothing out of pocket, some had a high deductible. And the final conclusion was patients couldn't make the heads and tails on what was necessary care versus unnecessary care, and people's health outcomes weren't that much better, which calls into question whether giving somebody a health insurance card is the single best way to lead to better health outcomes. And I, as a country, would like us to focus on that, because ultimately that's what matters. Quality of life is driven by better health outcomes, making sure that as we're spending more dollars, we're getting better outcome. An analogy I give sometimes is our cell phones. We spend a lot more on our cell phones these days than we did 20, 25 years ago. I think the vast majority of people think we get a lot more value. And that should be the goal in healthcare. If we're going to spend more money, then we should get a ton more value, better outcomes. And just as important, stop doing the bad stuff. Stop wasting money that's not leading to better health outcomes. That's how low the bar is in our current status quo, that we can't even stop the bad stuff. And so we need to make sure that we're focused on that. And I'd like the public policy world not necessarily leading on all of these things, because I think it's hard for them to be as dynamic as they need to be, but at least supporting an ecosystem and rewarding the innovators that are able to move into that space as quickly as possible.
Okay. Yeah. I want to dig into that RAND study at some point. I'm going to put a link to that in the show notes because that sounds fascinating. I had no idea about that. So thank you for bringing that up. It was interesting to hear your point around, maybe the subsidies that were given could have been provided in a different way, for not forcing everyone who you want to have access to care, potentially not forcing them into a system that many already perceived was flawed. And I think I'm likening that or drawing some parallel between that statement, which I think to take a step back is there are a lot of flags and points to this concept of giving cash allocations and letting the individual decide how to spend the resource that the government is going to provide. And that's a whole other story. G. Bai wrote an article, I believe, in Forbes that came out the other day where she's talking about cash allocation and how that is potentially a better solution than forcing people into a single path with regards to accessing resources. But it is similar, at least in the mechanism, to what we had discussed, or like what I brought up initially on the call or when we first started, around using cash as an access tool, albeit within the context of the system that we're saying that might not be the best mechanism to access the resource that is healthcare. But cash as this agnostic tool for commerce, or excuse me, not commerce, access, agnostic tool for access. I think it's an interesting dynamic that whether you're in the context of the insurance system or outside of the context of the insurance system, cash is the ultimate resource. Obviously, it drives economy and that's our currency. But I guess what I'm taking from it is at its core, let the end user, you give the end user the absolute unit of resource, i.e. commerce, i.e. give them the ultimate resource to access care, whether you're paying for premiums or paying for directly for care, and let them decide. I think the policy 2002 in Texas, and I forget the number in Tennessee, I think hinges around that same concept. Would you agree?
Yeah, just for listeners, just to give a little background. So where this initiative came from, we call it Patients' Right to Save. There's a couple pieces to it. There's a few of us policy thinkers who are looking at the landscape, and there's a lot of problems in the current structure of the system that we were not going to change overnight. We're not going to get rid of the tax exemption for employer-based insurance anytime soon. In fact, when John McCain suggested that in the presidential campaign, Barack Obama's campaign spent the most money on any single issue on that one proposal in attack ads. So I think that speaks to the political nature of that proposal, such as that. So Congress, as dysfunctional as it is today, I don't think is going to tackle something like that. As we looked at the landscape, we were trying to think, how do you better align incentives within the status quo to reward providers who are providing more ethical pricing, for lack of a better phrase, that's not going to bankrupt somebody right away? As you look at the statistics, most of your listeners familiar with just the terrifying trends that we're seeing, whether it's individuals' ability to pay for something out of pocket, what's in their savings, cost of living, to the increasing deductibles that we face with most health insurance plans. It's just affordability is becoming a serious issue. And you have one side kind of proposing, we'll just take it all over and socialize it and have taxpayers spread the cost. Huge unintended consequences, I would argue, in that sort of proposal. And we can go down that rabbit hole if you want to. But there's another alternative here, which is to say, just align incentives properly, or at least more properly when you can. And so one of these proposals that has floated around for a few of us for a number of years, and now a handful of states have passed, the state of Maine, Texas, Tennessee, and Arizona has a version of this now, says that, look, if there's an ethically priced cash-based provider, when we talk to those cash-based providers that are popping up in the market, they're saying to us, we can provide a quote unquote discount or a better price because we're not having to deal with the insurance company. You're going to pay us right away. We're not going to have to wait for 90 days or 180 days as we fight with somebody over whether this was a necessary service or something like that. And so the proposal is pretty straightforward. Simply says, if you find a cash-based provider that's below the average in-network rate for your insurance company, then the insurance company, when you submit proof that, hey, I went and got this MRI, it's medically necessary, you would have covered it anyways, you need to give me credit towards deductible. And this was based a little bit on anecdotal conversations we're having with people. And we'd see family members and friends and others say, I could go over here. For the few times people saw the price ahead of time, with that caveat, and hopefully things are getting better here. We've worked hard for the last few years on that. And I've worked on that issue, price transparency in general, since 2012. But for those that saw the pricing, we would still hear people say, I'm going to go to the one that's twice as expensive because I'm paying all this money for insurance. I want to at least get credit towards my deductible. Completely economically irrational, but that's how they acted. And so we said, what if we knock down that barrier and simply said, you will no longer be penalized by going out of network if the person's out of network, or even if they're not out of network, and you pay cash as long as it's less expensive, you should get credit. So that was the rationale behind it. We think that it's one of the better proposals, not perfect. We would like to redesign the whole system, but if we're stuck with the current system at the moment, what is one way that at least slightly more aligns incentives for both the providers who are offering the better deal and for patients who are increasingly paying this entire cost out of pocket because their deductibles are higher.
Okay. Thank you for that thorough explanation. Okay, so now I'm going to go back to what we were talking about, the previous kind of bullet point, if you will, around infrastructure, talking about the cash as an alternative to subsidy. And now we're talking about cash as an alternative to the deductible. I think you just touched on it. What I'm getting at is the fact that we just have a broken system, and broken with regards to infrastructure. And everyone knows that's my issue with the industry, and that's what we're working on. But I think it's something that still is lost on people when talking about the root cause of a lot of the issues that we're contending with in healthcare. One of the things that you touched on earlier was the inability to identify what is appropriate from a treatment perspective and what drives, what improves outcomes. Healthcare is complex, 16,000 procedure codes, another 68,000 diagnosis codes, 1,000 DRGs. Like it's tough to know exactly what modalities are appropriate, and that is ever shifting, thankfully, with innovation. But we're stuck on a system, on a chassis that's been around since we were kids. And I know I'm beating a dead horse when I say this, but I just like to remind everyone that we're dealing with a broken admin system. There's a reason why people attribute 30% of our spend towards administrative waste, specifically pricing failures and admin complexity, and $1 trillion close to being thrown in the garbage because of a broken system. And as I've gotten deeper into understanding how to further and how to better distribute this concept of direct care and transacting using cash outside of the system, it's led me to understand a little bit more about why care is so expensive and how that broken infrastructure, the convoluted infrastructure, allows for bigger chunks and slices to be taken out of the equation without anyone really knowing, aside from those who are getting fat off of it. And so guess what, the point here that I'm making is all comes back to infrastructure. And to your point, I applaud you for taking a simplistic approach towards, look, we want to give providers economic incentive to continue offering fair pricing outside of the system. They're doing so because it's cheaper for them to collect revenue than having to submit a claim, i.e. an invoice, follow up on that claim, and then get paid maybe 3 months later. So I think taking a simple approach is definitely the right one, but because you've been gracious enough to hear my concerns and listen and frankly process and respect and seemingly value my concerns. No, but I've seen how, or I fear that these bills that have been passed and that obviously have great intentions, that they could potentially be, what's the word I'm looking for? Skewed, perverted by insurance carriers, the way that they pervert a lot of things, seemingly always. But I'll be more specific. So the concept of cash and offering a lower rate to a patient than they would have paid towards an in-network deductible. At its core, that's illegal in states, specifically in Texas, which it's interesting that the law passed and no one kind of, not to say that you should have known or anyone really should have known, it's tough, but the sell side, provider side has grown so fearful of this concept of dual fees and charging patients different prices based on insurance status and what that could result in the way of regulatory scrutiny or contractual commercial scrutiny from the insurance carriers that that these providers are accepting contracts with in exchange for those potentially discounted prices. Accepting, and we'll take a step back, I'll give you an example. Patients insured, they have a high deductible, they're using their high deductible plan as catastrophic coverage, because they're not getting first dollar coverage, period. And so they're, instead of going through the system and subjecting the provider to the expensive billing apparatus, which is core of the brokenness, but it's subjecting the providers to that, they go and they pay cash, and the providers incent that. Insurance carriers see that as inducement, and where a provider is inducing a patient to go outside of the bounds of the contract that the patient has with the insurance carrier and that the provider has with the insurance carrier. And so right off the bat, if that patient does have insurance and they're choosing not to use it, although they are protected by the ACA and are allowed to access care without a claim being submitted based on those protections, should the carrier catch wind of that, then the carrier knows that not only is the patient in conflict with their relationship with the carrier, but the provider's in conflict with their relationship with the carrier. And the carrier's incentivized, obviously, to prevent that because they want people to rely on them and the infrastructure. They want people to keep going to the insurance directory to see where they can be seen, and need them to submit invoices and manage the payments so that we all need them still. It's people refer to it or liken it to being addicted to the system. Providers are addicted to the demand that they get from being on those provider directories. And Who wouldn't? That's the only way to get to for people to know that you're there is through directories. That's why we have the yellow pages, and that's why we have Yelp and Google, etc. The point that I'm getting to is this fact that at its core, though, that is the provider and the patient are in conflict with their contract. And my concern is that the carriers will go after the provider. They're not going to go after the patient, right? They want the patient to continue to pay premiums. And so the patients, they're seeing this as a deal, as a way for them to navigate the system more efficiently. And to your point, you're right. Like, it is a deal for them. They're able to pay less, although it might take them longer to reach their deductible. It doesn't matter. They're not getting fleeced by the contracts, even though those contracts are supposed to negotiate on their behalf. And so there's a problem at its core when the contracts that are being signed are greater than what the provider is willing to accept. And then that points to the infrastructure a problem as well, because they're willing to accept it because you don't have to go through the system. So the system and the infrastructure in the system is broken. Besides the point, the insurance carriers don't care about they care about the patient. That's not who they're going to go after. They're going to go after the provider. Why? Because the providers who they have to potentially pay once the patients meet those deductibles, if they ever do. And they're incentivized, although not as much anymore with the MLRs pursuant to the ACA, but they're incentivized to keep expenditure down, right? Insurance, they don't want to pay out. And so they also, not only do they not want to pay out, they want the providers to be, again, addicted to them. And so my concern with all this is, and I'll just come straight out and say it, that if the provider, patient goes and they submit the bill to the carrier that shows that they went outside the system, that the provider was accepting a lesser cash rate, the provider is going to be seen as in conflict with the insurance contract, in conflict with the dual fee schedule restriction, which in Texas, I think they call it the something around charging different prices for the same procedure, something along those lines. They call it a misdemeanor offense. I'll add a link to the show notes for that legislation. But my concern is, and this is based on something that I've seen in my revenue cycle career, is that rather than point the finger or notify the provider up front that they're in conflict with their contract, they're going to let the evidence mount, and they'll accept and collect all the potential contract violations that they can. And then come next year, when they want to renew the provider's reimbursement contract, they will, but they're going to renew it at whatever the cash price was, minus a few bucks. And I use the example, and I think I've used this with you and the team at Cicero in the past, is $125 office visit, provider's accepting $100. Patient pays $100 cash. The doc saves that 25%, a little less on the billing admin fee, and everyone's happy. The carrier is going to say, oh, cool. So that $100 should be our contract rate. You're in conflict with the contract. You're in conflict with law, but it's okay. We're not going to tell on you. We're just going to reduce. You're just going to accept this lesser rate. It's not going to be $100. It's going to be 80. And it's 80 because really, if you're accepting $100, then all the times that we paid you $125, you were defrauding us. You really would have accepted less. And so the $80 is to offset that. And if you don't accept the $80, then we consider you not only in conflict, but you owe us the difference. You owe us $25 times however many consults that you did, thousands. And so unless you pay that, then we're not only going to drop you and eliminate the demand from coming to you, but we will come after you. We'll sue you. And not only will we sue you, we'll then also notify the regulators that you were in conflict with regulation, and you might have some legal repercussions. That's my concern. I hope that is clear for the listeners. And I'm saying this all because I've seen it happen in the out-of-network world, where the provider is supposed to, and this is a gray line, the provider is supposed to collect on the out-of-network cost sharing. And if they don't, it's seen as inducement, and the provider is inducing patients to come to them and break their relationship with the carrier. And that there's a gray line there, but I've seen this happen where the carriers will send a phishing letter and say, hey, send me all of the proof that you collected this money from these patients out of network. And the provider doesn't have a contract with the carrier at that point. So they're like, F off. I don't owe you anything. No. But some providers bite and they take the bait. they send or they don't send or they respond saying they don't have it. And then not only are they bite and they send the documentation that shows that they were accepting a lesser rate. And every time that the carrier, or for every claim that the carrier paid 2 and 3x likely in the out of network world, what would have been paid via cash, what the provider actually accepted for that, they process that as an offset. And they do the same thing. We're going to sue you. You defrauded us and we're coming after you. I've seen this happen to the tune of over $1 million for a 5-person chiro group. And so if they're going to do that for a chiro group, imagine what they're going to do for a surgeon. That's the nature of my concern. I've seen it a couple times. It's fucked up, but yeah, sorry.
Yeah, no, I think it's a couple of things just in general response. I think first I'll return to my point saying that legislation is a result of negotiation and is not necessarily where you started or where you'd hope to end up always. Amen. So that's the first part. The second thing I would just say is I think it's going to be very interesting to see how this plays itself out. The intent of the laws that you're pointing to were to prevent people from discriminating and charging somebody exponentially more. And so I think the exponentially more here is the negotiated rate between the insurer and the provider. And so I think from a regulatory standpoint, this is probably a tad gray. And in Texas in particular, the Division of Insurance is issuing additional regulation on the law for how it should be interpreted. I don't know if this will be addressed or not, but these are the sorts of things that ultimately will come down to their interpretation. But I will say there are lawmakers in these states who I think are pretty fed up with the behavior they've seen from insurance companies, along the lines of what you just described. And so if we start to see this, it would not surprise me if some of these legislators step into that. Now, with that being said, that's ideally not where you want to be. You don't want to be purely reactive and playing whack-a-mole as these problems are raised. And so I think it is worthwhile for those of us in the public policy space to be proactive and bring clarity, to pass follow-on legislation. And in fact, after we spoke, there was legislation in Iowa that started to reflect some of this to bring some clarity. And I'm hoping over the next 2 or 3 years, we can have some success in engaging in these conversations. I think insurance companies, what's interesting about this is for smaller insurance companies, I think they'll be fine with it because it'll be a way to attract more lives while allowing a quote unquote additional option for patients to go somewhere else if it's a better deal. They're often trying to control costs by cutting out providers and having a narrow network. This opens up some new options for them. So I'm not sure they would be the ones that object. It'd probably be the largest insurers that do. So yeah, I think this is a little bit of let's see what happens. Let's make sure that we're flagging these for providers and making sure that they exactly understand what is entailed here, that we have lawyers at the table looking at these things and trying to understand exactly the unintended consequences. So often in public policy making, you're thinking in the back of your mind, how is somebody going to game this? What's the unintended consequence of this? And we don't have the hubris to think that there won't be some of those that emerge. I think we're just believing that the status quo is so unsustainable that we have to try something different. We do seem to have these forces or trends emerging, greater price transparency, more players in the cash-based or direct contracting world. I think your issue goes away for somebody who's purely cash pay. Absolutely. They don't have the contract with the insurers to be concerned about. They may be the ones who take most advantage of what we've put on the table. That might be where it ends, but I don't think that's insignificant, giving patients and providers an option to now open up all of the individual and small group market to this, or state employees. In the example in Tennessee, they open this to state employees. Like, that is a significant opportunity for a provider to say, I wasn't going to jump from being employed by a hospital, but now I know I can be a direct cash pay because people can find me. There will be a market for people to find me. And as long as I educate my patients and my advertising saying, come to me, I'm less expensive, I will process the paperwork for you with the insurance company and not have those concerns, I'm hoping, and we're crossing our fingers that in the next 5 to 10 years, you have moved the needle for a subset of the population. We are not under the illusion this solves healthcare. There are too many issues to be solved by some simplistic of an answer like this. This is a little bit more of a lifeboat option for patients and for providers who we have heard the desire for them to do something different. And if this helps them jump in a way to, and we've seen this anecdotally where some state employees in Kentucky and Florida and New Hampshire are then paying patients to go to lower cost options and new options opening. That's, I think, what we're hoping to induce here is more options. And what's the ripple effect that we hope to see there is that it actually benefits everybody in the market. There was some interesting research that came out of California when they moved, slightly different context, but similar type principle, when they moved to reference-based pricing. And there were some academics that did some work, and 75% of the savings as a result of the lowered price in reference-based pricing was actually realized by people who weren't state employees. They were in the commercial market. But because providers knew all of a sudden there's going to be a market who finds me, the state employees, they opened a lower cost option. Most of this was around surgery. And people walked through those doors having no idea that they were 25%, 30, 40% cheaper than other options in their area. I think that's what we're hoping to see, that regardless of whether you're uninsured, have individual insurance, small group, you're in self-insured, ERISA plan, wherever you're getting your coverage, some of those financing issues that we've pointed to, you can still take advantage of this. You may walk through the door at a lower cost option and not even realize it. But your current concerns are not, I don't think, unfounded based on some of the behavior we've seen in these markets in the past, and certainly worth us spending more time diving into.
Amen. And thank you again for listening. You never know when you reach out. And again, obviously the intentions are great. And I would love to see more sweeping legislation. Frankly, I would love to see legislation where they remove any uncertainty around the dual fee schedule restrictions, because I think that's the uppercut combination to this, is completely eliminate any uncertainty so that is no a barrier to commerce in this way, because then the insurance carriers don't have any leverage, or at least don't have the leverage that I fear that they will use against the provider community. And I think, to your point, the smaller carriers, the self-insured employers, these micro plans, if you will, who in many instances are serving tens of thousands of lives in any region, they are incentivized to accept this trend. And I think that we've seen that in formalized in policy plan design, in general, where you see a lot of increasingly plans now anchoring around not only direct primary care, but also this concept of cash payment for specialty care, and accepting cash payments and having that be reimbursed through the plan, essentially using, again, cash as the mechanism by which the plan reimburses the patient who pays the doc. I think that gets back to our roots and where healthcare was before it got perverted by managed care apparatus and having to wait for insurance to accept, approve, or deny services before patients can take that next step. I think, in this instance, getting back to the basics is a good thing, and it'll be interesting to see how we're able to adopt both the efficiencies of cash with what I believe to be the original intention behind our insurance reimbursement system, and really the reporting, the invoicing system, those 16,000 procedure codes and the diagnosis codes, the DRGs, like that's all come down to and intended to streamline population health management. And the reporting of those codes is intended to be able to drive insights that would allow for decision makers to impact and change and be nimble around not only plan design, but really clinical pathways and how to drive better outcomes. I think we haven't seen that really. I think that the claims-based system and the coding system has fallen way short of that. And I think we're trying to make up for it with quote unquote value-based care, even though value-based care is still very much reliant on that original system. But I agree that we got to do something. right? We're at an inflection point where people are suffering, and any initiatives to alleviate that pain, I think, is a win for everyone. So, thank you for taking the lead on that. Any plans to bring that to other states in the union? I know you mentioned Maine. It's already enacted and active in Maine, that type of
Yep,
legislation, at least.
it's been law since 2017, a variation of that. It's restricted a little bit to providers in Maine, New Hampshire, and Massachusetts. That was the legislative compromise that was needed to get that across the finish line. I think what gives me hope is anecdotally, we hear people taking advantage of this, whether they're in a state that actually has this or not. I heard of somebody, I think lives in Connecticut the other day, who shopped around for some, I think it was an x-ray, and was able to get credit towards the deductible from their insurance company when they paid the lower rate. So I'm hoping that there's multiple issues here. We can pass a law, but if nobody knows about it, then it doesn't really matter. It's the anybody hear a tree fall in the forest type situation. I think that's been a little bit of the challenge in Maine. The one area in which it actually the legislature went back and fixed something was direct primary care doctors were seeing patients and making referrals back into in network, and the insurance companies were playing games and saying, no, you have to go see one of our primary care doctors in network before you then can get this referral. And so the legislature in response went in and made it clear, nope, doesn't matter if it's a medically necessary service, you don't need to repeat that service. That points to two issues. One, some funny games, but B, that it was actually happening enough that it was causing a problem. And so, again, that's what I'm hoping will emerge is we'll start to hear of these issues. This is a little bit of a sad commentary that we in the public policy space are having to try to push these sorts of things. We wish it wasn't the case. That's just where we are at the moment. And I hope that there's more robust conversations between folks, entrepreneurs and innovators in this space, and some of us in the policy community that want to enable that. What I have been surprised when I talk to entrepreneurs is how often they're building business models around Medicare reimbursement, even if their service isn't for seniors. And I'm thinking, what is going on here? But I think that is a symptom of the financing challenges or mechanisms that we started talking about a few minutes ago, in that they figure if we can just get Medicare reimbursement, then we will be accepted into the commercial marketplace. We will have a set amount of millions of lives. And I think that's a challenge long term, is that if you have entrepreneurs basing it on Medicare, assuming that Medicare gets it right on reimbursement, which I think we have enough literature to say they don't, and more often than not, that we need to think long term about reforms that provide, whether it's large HSAs, whether it's there was a conference in DC a couple of weeks ago talking about converting Medicaid money just into basically like an HSA type account and allow recipients to decide, as you were alluding to earlier, to pay directly for care, to buy a different kind of insurance plan that they might want. I think we're a long ways away from that. It's probably worth starting those conversations now because it takes a long time. I hope that states lead on this because the politics, the light, the cameras are a little less bright in state capitals, and it allows them to think a little bit differently. Yes, the insurance companies are there. Yes, the hospitals are there. Yes, the doctors are there. All the special interests are represented. But I also think those folks, the state legislators, have to attend a lot of chicken dinners and bad eggs with their local chambers of commerce and other events, and they hear that for the last 15 years, healthcare is in the top 3 issues every year. And they don't want that to be the case. They want to talk about anything else, but healthcare remains a top issue. And so I think those state legislators are, quite frankly, sick of hearing it, want to do something differently. And there are a subset of them in a number of states, Florida, Tennessee, Texas, that are willing to push against some of the special interests to say, you've done just fine. You will continue to survive, but we need to try something different. And I welcome anybody that wants to reach out to me that's got policy ideas or barriers they're running into to have these conversations, or to add on to your constructive criticism of any proposal that we're pushing to say, we get your intent. Here's our concern. Here's a way to maybe fix it. Or have you thought of this? That's how we end up getting a better product in the long run. And hopefully Americans will benefit as a result.
Amen. And so, yeah, let's use that as a closing thought. I think the theme comes down to engagement and encouraging others to speak up. And I think that people don't oftentimes realize the power of their voice. And we're a nation of 300 some odd million people, and people with regard, whether it's voting or policy in general, feel that maybe their voice won't be heard. But look, if I was able to reach out and connect with you and fully feel that my voice was heard, I think that anyone could do the same. And I encourage all listeners to do that, not only with you, Josh, but in general. Thank you so much for taking the time to speak with us today. Where could people learn more about Cicero, about you, keep tabs on what you've been building and the progress around some of the policy that you've been pushing?
Sure. For Cicero, just ciceroinstitute.org. Folks are more than welcome to reach out to me on LinkedIn if you want to throw that in the show notes. I'm happy to have conversations with anybody who's either interested in scratching their head, how does policy get made? Why does it get made that way? Or for folks that do have ideas, happy to engage.
Awesome. Josh, thanks so much again for joining us, and talk to you soon.
Thanks.
That wraps up today's episode of Off the Rails. Remember, you can find us on Spotify, Apple Music, YouTube, and other major podcast channels. Don't forget to subscribe to catch all the content. If you like what you hear, please leave us a review and share it with your friends. Your support means a lot and helps us deliver more authentic takes from real change makers. Follow us on Instagram at GoOffTheRails and follow me on Twitter at Sydney Haytoff. Thanks again for listening. Stay genuine and stay true.